Hello, I'd like to begin by thanking the Epilepsy Foundation and the pipeline organizers for the invitation to speak to you today about the development of 2DG for treatment of status epilepticus, acute repetitive seizures, and delayed consequences of TBI. In the interval since the last pipeline presentation about 2DG, and a regulatory pathway has been identified with the FDA that will lead to clinical trials in 2021, and these will be targeted for development and approval of 2DG for treatment of status epilepticus, acute repetitive seizures, and delayed consequences of TBI. The clinical trials will be initiated by my colleague and collaborator, Dr. Nathan Fountain at the University of Virginia, hopefully early in 2021. 2DG is an analog of normal glucose or sugar, shown here in a molecular formula and in a molecular model. 2DG differs from normal glucose only by the removal of an oxygen atom at the 2 position. As a consequence of removal of that single oxygen atom, 2DG reversibly inhibits glycolysis in response to neural activity. In the brain, metabolism requires both oxygen and glucose for normal function, and both 2DG and glucose undergo transport and uptake into the brain via glucose transporters in response to brain activity, cellular energy demand, and neural circuit demand. Once 2DG and glucose are in the brain, 2DG and glucose undergo phosphorylation at the 6th position. Due to removal of the oxygen atom at the 2 position, 2-deoxyglucose-6-phosphate cannot undergo isomerization to 5-carbon fructose, and as a consequence, subsequent steps of glycolysis are inhibited. Administration of 2DG in rodent models of status epilepticus produces acute anticonvulsant actions, and in addition, also, there are acute anticonvulsant actions in isolated acute seizures. Here's an example of the effect of 2DG in the status epilepticus model of pilocarpine treatment in mice. 2DG dose-dependently delays the onset of status epilepticus, reduces its severity as measured by a standard scoring scale, and reduces the duration of status epilepticus. So there's dose-dependent increases in latency, reduced duration, and reduced severity of status epilepticus induced by pilocarpine in mice. Similar findings have been observed in status epilepticus rodent models with pilocarpine and canic acid treatment in rats. In addition to the actions of 2DG in status epilepticus, 2DG also demonstrates protection against individual seizures evoked by 6 Hz stimulation in mice and audiogenic seizures in Frings mice. In regard to the potential use of 2DG for treatment of status epilepticus, 2DG has a remarkable property of preferential delivery into brain regions which generate status and actually individual acute seizures as well. 2DG and glucose are preferentially delivered into brain regions with high energy needs, as is the case in circuitry that's generating status epilepticus, by activity-dependent neurovascular coupling, which involves neurons, glia, and endothelial cells in the neurovascular unit. Illustrated here schematically, the blood vessel and endothelial cell, and astrocyte and a neuron. These 3 cellular elements work together to deliver glucose and oxygen to brain regions with remarkable millisecond and micron precision. Very tight regulation of delivery of these essential nutrients, and also a therapeutic agent such as 2DG, which behaves just like glucose. Here's an example of how this works in status epilepticus in a 9-year-old patient experiencing focal status. Labeled 2DG is here shown in the region of the status epilepticus neural circuitry. So 2DG is preferentially delivered to the site where the status is being generated. This also occurs in individual seizures, here shown in conversion from a hypometabolic area, which is typical of an epileptic focus in a patient with temporal lobe epilepsy, into a region of enhancement with conversion from interictal to the ictal state with a seizure. 2DG also is preferentially delivered to neural circuitry which is undergoing stimulation. Here's an example of 1 Hz stimulation in the perforant path region, which is the input to the hippocampus of the rat. And you can see here that labeling extends from the site of the stimulation into the rat hippocampus. This has potential implications for combination therapy with 2DG administration and stimulation device therapy. In addition to these acute actions, 2DG has chronic therapeutic effects when it's administered after a seizure has occurred. This is a disease-modifying action which reduces progressive seizure susceptibility. This property has been demonstrated in the kindling model of chronic seizures. In this model, rats receive once or twice daily stimulation to evoke a seizure, and over time, the duration, severity, and intensity of the seizures increases. Shown here in an animal which is untreated as the black bars, and this is the rate of progression, the number of stimulation evoked seizures required to reach class 5 or secondary generalized tonic-clonic seizure. You can see that in an animal that received 2DG 30 minutes prior to kindling stimulation, there's a slowing of the rate of progression. It's about twofold, which means that about twice as many seizures are required to advance to this milestone state of a secondary generalized seizure. When 2DG is administered at the lowest dose that produces its effect, 37.5 milligrams per kilogram, and when it's administered immediately after the seizure or 10 minutes after, the same protection against progressive seizure susceptibility is observed. This is also due to the remarkable property of neurovascular coupling, which maintains increased blood flow and provides 2DG delivery for as long as 15 minutes after a seizure has occurred. This suggests the possibility that 2DG can be administered peri-seizure or after seizures to enhance its delivery and potentially provide therapeutic effects. So this is a novel anti-epileptogenesis effect enabled by neurovascular coupling. The potential therapeutic applications of 2DG for treatment of epilepsy and TBI include a number of opportunities that are a consequence of the novel anticonvulsant and disease-modifying neuroprotective mechanisms of 2DG versus all marketed anticonvulsant drugs. In epilepsy, it will be potentially useful for treatment of acute seizures, specifically status and acute repetitive seizures or cluster seizures. Potentially useful for peri-seizure administration, as we just mentioned. And there are potentially novel methods for delivery in combination with stimulation and device therapies that might increase the efficacy of device therapy stimulation and also reduce the delivery and dosing of 2DG to prevent toxicity. And finally, the chronic disease-modifying actions observed in rodent models may reduce epilepsy progression in people. In TBI, the protective effects of 2DG include prevention of development of post-traumatic epilepsy after rodent brain injury, specifically about a 60% reduction in the incidence of post-traumatic seizures after induction of brain injury in the strain of perforant path kindling susceptible rats, which are highly susceptible to development of post-traumatic epilepsy. There's also a reduction in secondary damage progression measured by CT and MRI scanning, and favorable therapeutic effects on learning and memory that may be relevant to prevention of problems such as post-traumatic stress disorder. The current commercialization strategy for 2DG would be to seek approval for indications including status epilepticus, acute repetitive seizures or cluster seizures, and for acute treatment after TBI to reduce post-traumatic epilepsy, PTSD, and possibly chronic traumatic encephalopathy. These indications are enabled by the observation in the most recently completed toxicity studies that single and limited repetitive dosing for these conditions can avoid dose-dependent reversible cardiac vacuolation that occurs at higher doses after 2 weeks of treatment. The immediate goal is to seek FDA approval for orphan indication of status epilepticus, with next steps including IV, PK, and tolerability and safety studies in epilepsy patients, as well as oral PK safety and tolerability studies, phase 2 dosing leading to phase 2 dose ranging studies in emergency room and ICU patients with status epilepticus, and eventually to phase 3 studies in these same patients. So the long-term goals will be to pursue FDA approval for acute repetitive seizures using a similar strategy with oral administration, also pursuing FDA approval for acute treatment of TBI indications using both oral and IV administration, and combined drug and device therapy in refractory epilepsy that would require oral administration. I'd like to close with acknowledgement of the supporters and contributors, current support coming from the NIH, NINDS, NIH NCATS or Bridges program, and the Wisconsin Alumni Research Foundation. I'd also like to acknowledge the past support of the Epilepsy Foundation, Epilepsy Therapy Project, the U.S. Department of Defense, Citizens United for Research on Epilepsy, and Neurogenomics Incorporated. Major collaborators in this work include Nathan Fountain at the University of Virginia, Pramod Terse at the NIH, and my colleague Robert Kotlaski at the University of Wisconsin. Thank you very much for your attention, and I'd be pleased to answer any questions.